Okay, I believe we are live now. So welcome everyone. I see here the number of participants increasing. I'll let everyone join and get comfy here a little while. And I would like to say welcome to Dr. Omar Ikram. Omar, how are you?
Thanks, Fabio, for inviting me. I'm good. I'm good. Hope you're keeping well over there.
It's been all right. Yeah, it's been an interesting time, to reassess and understand what's going on there with different. I got my phone here broadcasting. Give me a quick moment here. There you
Yeah,
go.
we were just talking. We were just talking before about how, although it's been a tragic time, it's also been a time for us to think differently and maybe use some different types of educational material. And we have had some beneficial things educational-wise anyway from this.
I couldn't agree more, Omar. So it's really uh, a time to reinvent yourself and to
Yep.
consume information in different ways and to enjoy your family in different ways.
Yep.
So, of course, this is a very negative moment in history,
Mm.
but people are really making, some pretty good silver linings out of it. And I think education, dental education in particular, it's been tremendous to see the effort by educators such as yourself, to really go out of your way beyond even what you are already doing and, making information accessible and making sure that, schools are closed and courses are not happening, congresses are not happening, but people are in contact. I've seen, Dr. Anthony Mack, starting a
Yep.
fantastic new group as well on social media.
Yes. Saw this.
And this is amazing to see the quality of the content that's coming out of that, and tremendous. Yeah. And look at us here. I mean, just our humble initiative here. Of course, I have a strong name here to back it up in yourself, Omar. But we are here.
You're
We
too
have
kind.
about 370 guests here. Thank you all for joining, and we will really make it up for your time. We appreciate your time
Yes.
and joining here, and I'm really looking forward to this. So why shouldn't we just get started to it? So Omar, just very briefly, I'll let you introduce yourself because you have a slide in there.
Yes.
And I'm sure we'll have a very interesting discussion at the end as well. So we have a Q&A panel here, everyone, that you can use to send your questions. And then, of course, we may not have the chance to answer all of the questions, but we'll try as many as we can. So please interact. And we will also send you some polls during this presentation based on the topic that Dr. Ikram will be approaching. So be prepared for that as well, and we'll share the results live too. And of course, we can, afterwards, we will issue a certificate that we plan to send to you by email. May not be immediately, may take a few days, but we'll be right on it as well. So Omar, we've met last year in Asia.
Yes. Yes.
And you gave a presentation that was quite similar to this, but of course it's
Hmm.
ever changing, always, upgrading, always putting a few more things here and there. And I was just telling you before went live here, how impressed I was because, of course, this can be treated as one of the most elementary topics in dentistry, irrigation and
Mm-hmm.
medication in endodontics. And the way you presented this last year when I saw this, it was so easy and logical that I really appreciated that. I didn't have that view upon irrigants until the moment I had the opportunity to see this presentation. So um, I really am excited about all of you that are with us here tonight to follow this presentation. Omar is a tremendous dentist, educator, such an international experience that he will share with you as well. And Omar, I guess I'll just, keep quiet here and just enjoy the ride.
Thanks a lot, Fabio, for inviting me to do the talk tonight. And thanks for everyone for giving up your spare time to listen to the presentation. I really hope you can get as much out of it as I did when I was planning this talk. So we're going to talk about the ideal irrigation medication strategy because one of the questions I am asked is irrigation and protocols and medication protocols, lots on the social media pages. So firstly, a little bit about myself. I was actually born in Christchurch, New Zealand, in the South Island of New Zealand. And I did my university, first degree at Otago University in the deep south of New Zealand. After graduation, I went back to Christchurch to live with my parents and spend a year working in private practice in New Zealand before moving to London in the UK. When I arrived in London, the world of dentistry was very different to New Zealand, and there was lots of patients, and it was NHS, lots of hard work, lots of long days, lots of emergency patients. So I got used to a lot of endodontics, a lot of extractions. And after getting experience, I decided to make use of the experience that I had got and transform that into a master's. And I always encourage new dentists, if you get experience and you really like something, then get the official certificate or degree for that area, because that qualification is worth it. So I did my specialist training in endodontology at King's College London, and then I moved to Sydney and started a practice called Specialist Endo Crows in Sydney's North Shore. It has some social media pages. You probably may have seen these, but Crow's Nest is an area in Sydney's North Shore. So tonight we're going to talk about a few things, but we want to understand how common irrigants and medicaments act, the basic stuff. We want to gain a greater knowledge about advantages and disadvantages of these products, and also learn what happens when we mix a few of these. A lot of questions about mixing, and can you use this before you use that, and if you mix these things together, is it better? And we're going to cover a little bit of the commonly mixed irrigants and medicaments. Learn a little bit about the future of irrigation medication and where that's going. So just a bit of background. Bacteria within the root canal system are basically what we're trying to remove. The reason why is that this chap called Kakahashi here in 1965 did a paper with a few others and basically made a hole in some rats' teeth, and the ones that had the germ-free rats didn't develop any abscesses. In fact, the pulps of the teeth actually closed over with a dentine bridge. The teeth of the rats in the normal environment developed abscesses and apical periodontitis, and that was the first study that showed it's bacteria that cause apical periodontitis. So if we don't have bacteria, we don't have apical periodontitis. So then everything that we do is now aimed at removal of bacteria after the study, and the other studies were done on monkeys, and there's obviously human outcome studies on this as well. So removal of bacteria is the prime focus of endodontics. If you can get a negative culture, which is Sjogren's paper, then the chance of healing the apical periodontitis radiographically is in fact higher as well. So this is correlated to healing as well. So that's what we're trying to get a lot of the time. But we also have to be mindful that we're trying to preserve the tooth as well. So healing of apical periodontitis is important, but preservation of dentine and restoring the tooth correctly is also important. Instrumentation of the root canals, if we do this without using medicaments and if we just use saline as an irrigant, around half of the samples will be free of cultural bacteria from the root canal system. And this is a classic study again. So if you're a student and you're wanting classic studies, this is the slide with all the classic studies on it, a bit of background information before we get to the fun stuff. If we supplement the irrigation or supplement the instrumentation with both sodium hypochlorite and EDTA, 80% of the samples had no bacteria after 5 visits. And this is just paper point sampling from the main canal. Another classic study with Bistrom and Sundquist. And with calcium hydroxide, we actually will prevent regrowth between appointments, but if we don't use any medicament, then we actually get regrowth of bacteria between the appointments. There's leakage, there's nothing in the canal to stop them from multiplying. So this is another study, but this is the reason behind our intracanal medicament. So basically, if we dress the canals for 1 week with calcium hydroxide, this will achieve a negative bacterial sample as in Sjogren's study in 91. So his study showed that a 10-minute dressing with calcium hydroxide wasn't effective, but a 1 week dressing was effective. And we're going to get on to dressing and how long you dress for and things like that in a minute. So what are irrigation and medication? So irrigation is essentially using a liquid to wash out the root canals of of a tooth. The purpose of it is to disinfect the root canals and also remove smear layer and debris. Okay, so medication is placing of a medicament inside the root canal to eliminate microorganisms, prevent growth. So that's bacteria, viruses, and fungi. This is a nice little slide. I spoke to Ramachandran Nair many years ago when he came to King's College, and he spoke about the use of environment. So the environment being important to support the microorganisms. So if we see here the elephants, what he said to me was actually, it's not the shooting or the hunting of the elephants that's damaging, it's also that it's destruction of their environment. We see this a lot in our nature. So when we do treat root canals, we destroy the environment of the bacteria. People always show you those decalcified sections of teeth, and they will say, how does endo work, or how does root canal treatment work? If we have so many nooks and crannies in the tooth, how can we disinfect it efficiently? Well, this is the reason. It's because we are actually changing the environment inside the root canals and making it less favorable for microorganisms to thrive. So we have lots of different irrigants, and we're going to cover them first. So there's sodium hypochlorite here. You can see the Clausid V, the viscous sodium hypochlorite. EDTA, you have 17 and 15%. Chlorhexidine, that's 2%, and citric acid. But I won't speak about citric acid tonight much, but it's similar to EDTA. So irrigants can do all sorts of things. They can actually show us where the canals join. I'll try and see if I can get this video working.
Omar, if you go maybe to arrow options on the pointer options.
Oh, yeah.
Pointer options, and then at the bottom, arrow options.
Oh, yeah. Visible.
And then...
There you go. Fantastic. So this is a root canal system that I've cleaned out, and you can see if I put the irrigation into the mesiobuccal canal, it comes out the palatal canal. So you can see this under the microscope, and so this indicates that the canals join. Essentially, they may join early, they may join late. You don't know. In fact, one of the really interesting tips that I sometimes post about is the Castellucci tip, which he documented, which is where you put a GP point in one of the root canals and then a file in the other root canal. Like, say, for example, in that tooth, you may have put the gutta-perca cone into the mesiobuccal canal and a file in the palatal canal. Then you remove the file first. Always remove the file first, and then have a look at the GP cone, and you will see a mark on the gutta-perca cone where they join. So it shows that they do join, because you usually can't get the file all the way down the canal because it's jamming against the gutta-perca cone, and it makes a mark on the gutta-perca where that join is. So that's more helpful than this type of technique, but this technique is useful for showing you early on that the canals join. Obviously, you can do this very much earlier than you can with putting gutta-perca cones and files in the tooth. So sodium hypochlorite, Fabio's favorite slide in the talk, this one. Think of sodium hypochlorite, for all those students and people learning and wanting to do something easy to remember, think of sodium hypochlorite as the person at the party who always wants to interact. It's very interactive. It's unstable and interactive. So this is behind a lot of the comments about sodium hypochlorite. Basically, sodium hypochlorite is essentially going to always interact, and this is what I mean by the questions about sodium hypochlorite, whether you should mix it or not. Well, it's very reactive, and so if you use things in the root canal, it will react with it. In fact, it's reacting all the time against dentine, against the biofilm, against pulp tissue. You don't really want to add things for it to react against which aren't going to be removing bacteria. So we'll talk about that a bit. Okay, so sodium hypochlorite is the most common used irrigant. So there's a couple of really key things about sodium hypochlorite. It's a tissue solvent and it's antibacterial. So there's not a single irrigant on the planet that does both, tissue solvent and apart from sodium hypochlorite. And the reason why it is tissue solvent and antibacterial is it's very unstable. So the colored comments I've got here, you can see highly unstable. These colored comments are for people who want that extra few marks in an exam or a viva, or they may be fellowship candidates. So the reason why it's highly unstable is that chlorine ion is in a positive state. So unlike table salt, which is chloride with a minus, you've got the chlorine is like, the ion has got a positive state, so it wants to react. So it's very reactive. And by being reactive, it creates a lot of, it has free chlorine ions. And this again is why sodium hypochlorite is so effective as opposed to something like peroxide. So hydrogen peroxide is a similar kind of material, but it really doesn't have the chlorine. So the free chlorine is what dissolves tissue. So hydrogen peroxide doesn't dissolve tissue. That's why you can use it to clean your wounds and things like that. It's lacking in that property. So sodium hypochlorite has a saponification or soap creating effect on fatty acid salts and permits penetration. And so when it creates these degrades the fats and creates fatty acid salts, which are soaps, that will reduce surface tension. So what surface tension is basically, if you take a leaf and you drop some water on it, often you have those little droplets of water. That is a high surface tension. So yeah, it's a surface tension there that's very high. It basically reduces the surface tension if you have a a soap. So essentially, you get more contact of the material with the pulp tissue, and then that improves the dissolution. So it lowers the surface tension. High surface tension is where you get the droplets of water on a leaf. And it produces hypochlorous acid, and that basically degrades amino acids. So this is, again, the chlorine. It's very unstable, creates these things. And hypochlorous acid also interacts with the tissue, creates chloramines, and that helps impede the cell metabolism. It's kind of like a circular situation. It's creating that, lowering the surface tension, more of it's interacting, it's creating hypochlorous acid, so creating chloramines, they're impeding the cell metabolism, and so on and so forth. So it dissolves tissue, but then it has this, also has this high pH like calcium hydroxide, because it has the hydroxyl ion that is released as well. And then the pH is high, and it works like this. So the question is really, are there any cases where you never use sodium hypochlorite in endodontics? And the answer is actually there aren't any cases that you would not use it in. In fact, so in other words, you would always use sodium hypochlorite. And the answer really is not that. Like, you might try and say, oh, but if there's no bacteria, like it's an elective endodontic, but you always have tissue. And getting back to that slide with the elephants on it, if you remove that tissue that's the food for the bacteria, you will push those bacteria into a state of starvation. You will prevent them from flourishing. Think of it this way. If you have a city and the food sources start to dry up, it's never a good thing to have more people. The same would go for bacteria in a root canal system. If you have lots of food, of course, the bacteria will flourish. They'll make more bacteria, they'll grow, they'll flourish. If you reduce that food level down, the pulp tissue, which is the food, the energy for bacteria in the root canal system, if you reduce it, and of course the bacteria will not want to flourish. They will go into a more dormant state. They will starvation state. they have interactions. The biofilms interact and notify each other, you know, what's going on in the biofilm. They do have quorum sensing, it's called. So we want to do that. We want to reduce the bacteria, but we also want to reduce pulp tissue, which is the food bacteria, and to push the microbes into a more dormant state and less, give them less opportunity to flourish, essentially. So you always use sodium hypochlorite in endodontics as an irrigant, always. But here's another question: what concentrations? Now, we have lots of different types. In Australia, the common concentrations are 1% Endosure, 3% Canal Pro, 3% Clausid or Clausid V, which is the viscous sodium hypochlorite. The viscous sodium hypochlorite is useful if you don't want to extrude it. Endosure Forte, which is it's just 4% Endosure Forte and 6% Canal Pro. So they'll tell you at university it's no difference in the antimicrobial action / effectiveness between concentrations, and this is absolutely true. However, there is a huge difference in the tissue dissolving capacity of these different concentrations, and if there's a difference in tissue dissolving capacity, there is a difference in biofilm dissolving capacity. So when you use a 6% solution, that is around 6 times more efficient at dissolving a biofilm or tissue than 1%. So if you're going to see the patient 2 or 3 times to do the treatment, well, of course, 1% should be fine. You're going to see them so many times. You're going to clean out the root canal so many times. You're going to use calcium hydroxide, hopefully, between the appointments. You're going to get tissue dissolving. You're going to get denaturing of the proteins in the tissue. So it doesn't matter if you use 1%. 6% is good if you're doing a lot of quick single visit treatments. So I would tend to use 6% or 4%. Clausid can be useful if you're worried about extrusion. The viscosity of it is higher, the Clausid V. Heating the irrigant will also help to increase its tissue dissolving properties. So I actually read a study the other day that showed that if you heat 1% solution up to 60 degrees, you will get the same dissolving property as 6% sodium hypochlorite. So it has to be quite warm. So the only way you can do that is really do it within the root canal. You cannot heat up a syringe and inject it, because by the time it gets the needle tip and goes into the root canals, it will actually be 37 degrees or close to that. So it really won't offer any benefit. So the only way you can really increase the dissolving capacity is within the root canal system. And that's via heating tip or ultrasonic activation to heat the solution within the root canals. But you do have to be careful not to overheat it. How long shall I irrigate for? That's another question. Retamoso study, there's dentine slices with Ephicalis biofilms on them. 5.25% sodium hypochlorite was the most that they used. They had all sorts of concentrations for all sorts of different times. 40 minutes was the quickest time. So the quickest time was a 5.25% sodium hypochlorite dribbled on the dentine slices of Ephicalis biofilms for 40 minutes. So here's a common question that I get as well. Can't I just use supermarket bleach rather than the bleach sold by dental companies? Well, in Australia, obviously we have the Therapeutic Goods Administration, or TGA. So the supermarket bleach is not approved for use in the root canals for people. The reason why is it's not titrated, so the concentration is a bit not quite sure. If you look at your supermarket bleach, it will say up to 5.25%, which means some of it might be 4. Really, we can't really recommend products like this that are not designed for use in humans. But there was a study by Clarkson who looked at Milton's, which is a commonly used product around the world for root canals irrigation, a sodium hypochlorite product, but it doesn't have a surfactant which lowers the surface tension. So it took 10 times longer to dissolve tissue than any other products they tested. And basically it's related to the beading of the sodium hypochlorite on pulp tissue. So that it's like I said before, it's like a leaf in the rain. You get these droplets that sodium hypochlorite's acting on the tissue in this part, this part, and this part, and this part. If you lower the surface tension with a surfactant, that will then spread across the pulp tissue and it will interact with more surface area. Here's a shot of some sodium hypochlorite dissolving tissue. So not only is it helpful for dissolving biofilms, dissolving tissue, but we also can get dissolution of tissue of the isthmus of canals, and we can see the canal. So here's a case of an upper 6 first molar, and I was looking at down the microscope and I was like, I'm pretty sure there's an MB2 here, but let's have a look. So I put a few droplets there, and there we go. There's the froth that shows that there's probably an MB2, and there we go. So I opened it up. It's one of those days where you hope that you don't need to find it and treat it, and you go, oh, it's there. But anyway, that's another use for irrigants and sodium hypochlorite. When we look at irrigation of irrigation needles, this is something that we need to think about as well. Like, this is another commonly liked question on the Facebook page, Specialist Endo Crows Nest Clinical Hacks. So when we look at gauge of needles for irrigating with, don't forget that we should be looking at perhaps the size of file, because if we prepare a root canal to an apical size of, say, 60, in this case, a 23 gauge needle would make it to the apex. Bear in mind that irrigation needles are 0 taper most of the time. There's a few that tapered, but the 0 taper, so it's a size 60 all the way up. But of course, that's quite large, and 25 is also quite large, size 50 K file at the tip. And we have 27 gauge. So stock gauge needles would be around 27 gauge, the mono-eject ones, which you can get. But then, of course, with our microendodontics, we cannot use a 27 gauge needle. We have to use 30 gauge, which is 30 K file size. And there's also 31 gauge, which the Navi tips. There's a double side ported Navi tip you can get, which is double the flow. Obviously, that's an advantage. We certainly find that double side port with smaller gauge needles is the way to go, because it's double the flow. It takes a long time to get the irrigants out of a 30 gauge needle, but a 31 gauge needle is also difficult. So to have the double side port is very helpful here. Here's me just working in some sodium hypochlorite, just an example of how I use it. So you can see this is the Wave 1 Gold Glider, and you can see me working in the sodium hypochlorite. The other thing to remember is that the root canal system actually contains more bacteria coronally than apically. We're obsessed about the apical region. Why is that? Because we're basically we basically find the apex hard to reach, and it's the hardest part to clean. But realistically, the root canal system has got more bacteria at the top of the root canal than right at the apex. And this was a study by Love in '96 using Strep gordoni. So when you treat these teeth, bathe them in hypochlorite to start with before you start filing. That's the one thing I would tell you to do, is to bathe them in hypochlorite. Activation. Now, we talked about irrigation and getting the needle down there, but there's ways you can avoid having to get the needle all the way to the apex, because that creates a danger for hypochlorite accident. Also, it creates what called the vapor lock. Now, vapor lock is different to taper lock. Taper lock is where the gutta perca point doesn't get to the bottom of the canal, because it's locking up the top of the root canal. But vapor lock is where you have this air bubble between the end of the irrigation needle and the apex of the tooth. And all of our irrigation needles have some kind of vapor lock. So basically, that's that area that's why we don't have lots of hypochlorite accidents, because you would have to pump the irrigant solution really hard through that vapor lock and through the end of the root to get that flow through. So in fact, most hypochlorite accidents actually occur from perforations and then injecting through that rather than through the apex. So this is a vapor lock. So it has some good things, like it stops you getting a hypochlorite accident, but it has some bad things, as in the irrigant doesn't reach the apex. So what you really need to do is activate your irrigants to get them down there. And this is well documented in the literature. This obviously stops vapor lock, because you don't get the bubble forming, because this is just working it down. You get a thinner instrument and it will move the irrigants down. So, but also activation of sodium hypochlorite is thought to create acoustic microstreaming and rapid fluid movement. And acoustic microstreaming we'll look at in a minute. It's like a vortex-like motion, and I think this occurs, and it's got to do with pulling bacteria off the walls and circulating the irrigants. This is possibly a helpful situation. A cavitation, we don't know if this occurs with our activation products. Cavitation is essentially liquid bubbles exploding, and they're supposed to create force on the biofilms and tear them off the walls. Again, another way of removing bacteria. But I really think that with activation, it's all about this overcoming this vapor lock, circulating the irrigants, because there's a lot of difference between hand activation and managing to get the irrigants in the areas you want to. And I think flow of irrigants is really important. So we have a couple of examples of sonic activation. Here's the endo activator. You can see this vortex. That's the acoustic microstreaming. Can you see the whirling effect? And so this sonic activation is around 180 hertz. So quite low power. As a result of having low power, low frequency, or a low oscillation, very safe, has plastic tips. The tips aren't going to damage the root canal system, but very low oscillation, you can see. And there's a few good studies to show it doesn't extrude irrigants, which is, again, part of the whole activation situation is you won't get much extrusion of irrigants with light sonic activation. Here's the Eddy Endo, which is a really great system I've been using quite a lot. You have to have an air scaler, and you hook up these plastic tips. So the plastic tips you can screw onto the air scaler, and this has around 6,000 hertz. So this is a much higher amplitude. And you can see the difference between endo activator and the Eddy Endo sonic activation. So both sonic activation, but this is a more high powered, high frequency activation. You can see that it really gets in there, and the sodium hypochlorite really is circulating. So this is a really good product that I've been using. And there's lots of studies on activation of irrigants, and a lot of them look at the biofilms and removal, or not even biofilms, sometimes just debris in the root canal. So it's a very interesting one, like whether you activate or how you activate. Generally, the consensus in the literature is you should activate doing something, whether it be hand GP cones, whether it be endo activator, Eddy Endo, ultrasonic activation, but really the power is a bit debatable on what needs to happen, because of course outcome and is more related to lots of other things than whether you activate the solution. Then you've got ultrasonic activation. This is around 30,000 hertz, so 30 kilohertz. Again, with the increased power becomes increased chance of fracture of these metal files, damage to the root canal wall, and various other things. So really, I think sonic activation is a good way to go, and plastic tips of polymer tips are the way to go if you can, in my opinion, but each their own. So what is the disadvantage of sodium hypochlorite? Well, actually, funnily enough, originally I just said there was one disadvantage in this slide, but then I thought about it, and there's actually two. Here we go. Does not dissolve the inorganic smear layer. So it dissolves organic tissue beautifully, and that's one of its big properties for me. Like I said, getting rid of that environment, removing the food source, and dissolving biofilms. These are big features of what it does, but doesn't dissolve the inorganic smear layer, which is hydroxyapatite. So it has a weakness. It can't remove the smear that we create when we instrument the root canals. It's a tissue solvent inside and outside the root canal. So of course, if you inject the patient's face because you've got a perforation, or you push too hard when you irrigate through an open apex or resorbed apex, you can get a hypochlorite accident. And the symptoms of hypochlorite accident include pain. It spreads. So the reason why patients get pain, even though it's got local anesthetic, they've got local anesthetic, and is that it goes to the areas that haven't got any local anesthetic in them, because it spreads quite rapidly. Edema due to the inflammation, and basically body's trying to dilute the extruded material and combat it, and it's inflamed. So you get swelling. But some of you won't get swelling instantaneously, because most hypochlorite accents, I would say, that I've seen are pretty much less severe than the textbook ones that sort of come up and the patient's instantly in pain and his face swells up in like a couple of seconds. So it's less likely to happen. But you do have edema, and it might happen like a few hours later. Bleeding from the root canal. Now that's a really useful sign, because if you see bleeding in a canal that was previously cleaned out or previously necrotic or something like that, then you know that there's something awry. So when you see blood, and it's usually scarlet blood, and it's usually quite a lot of it, from a situation where you had no bleeding to like quite a lot of bleeding. Chlorine taste, the patient tastes the chlorine. Anesthesia or paresthesia of the area. Obviously, with these situations, we want to get the patient off to someone who knows what they're doing, because these can be quite serious. So how do we treat hypochlorite accident? Well, the treatment is aimed at dilution, information to the patient, pain control, evaluate what's happening, review, and refer. So we have to make sure the patient's looked after and feeling looked after, and we're right there for them because something's gone wrong. In fact, I saw a patient just this week who had previously had a hypochlorite accident 2 or 3 years ago, and it put them right off dentistry, and they're very nervous about any more root canal treatments. And even though the result of the root canal treatment was satisfactory, the psychological damage had been done, and unfortunately the patient doesn't want to really get much more done. But we're trying to convince the patient this would be an okay idea to do some other treatment that they need, and they definitely need root canal treatment on a couple of other teeth. So it can be quite damaging, but if you do the right thing by the patient, they will still like you and still respect you, and that's really what it's all about, caring for the patient. So dilute the irrigant with saline, wash it gently, don't forcefully irrigate, just gently dilute as much as you can. Tell the patient what happened. Irrigant solution has come out of the tooth, and it's quite noxious and not very nice, and it's going to cause swelling and things like this, pain. Pain control, additional local anesthetic is recommended, something long-acting. Paracetamol and codeine and ibuprofen. So I never get patients to take combined paracetamol and ibuprofen, because then basically my rationale for that is that if you do that, the patient says, yeah, I took 6 tablets or whatever, and you think, oh, it's not that much Nurofen, but it's getting to the maximum dose in paracetamol. So we're in trouble here. We've got a patient who can only take ibuprofen for the rest of the time because they've taken 6 tablets of combined medication. So it's better to have a knowledge that they've taken ibuprofen or they've taken paracetamol, but not both. I find that very difficult. Also, if you look at the packaging of some of the combined medications, they in fact say to take them at half the dose that you would, just because they know that if people overdose, they'll overdose on the paracetamol, which is quite toxic. In fact, paracetamol has a ceiling level of effectiveness. So if you keep taking it, it's just damaging your liver and it's not giving you any more pain relief. Whereas ibuprofen has a advantage that if you take a reasonable amount of it, it will actually exponentially help. So 400 milligrams of ibuprofen is less effective than, say, 600 and 800. There's actually a table on this that you should look at called the Oxford League of Analgesics. You can look it up online. There's lots of different things. So evaluate for paresthesia and anesthesia. Obviously, if you're worried about the way things are going, then refer the patient. Review the next day. Give the patient your mobile number. You know, if you've got any problems, any questions, please feel free to ring me any time of the day, and then just make sure they're looked after. Refer if the patient hasn't had any resolution. Refer to your local specialist. So EDTA, ethylene diamine tetraacetic acid. So it chelates the calcium ions. So this will actually remove the inorganic smear layer. So this will actually end up being a product you use a lot because sodium hypochlorite does not dissolve the inorganic smear layer. So it's a weak antibacterial ion due to the ion chelation that leads to cell lysis, and it opens the tubules. So the idea of EDTA is to open up those tubules. They open up the fins and ramifications where the smear must have gone into or blocked. Remove any smear that covers the biofilms in the root canal system, and basically just try to allow the sodium hypochlorite to get in there where it needs to get in there. When should we use EDTA? Well, you would use it all the time, but if you were doing a case like an open apex case or something that had wide root canal, you didn't create a smear, then you could conceivably not use it because you have no smear. So, but I tend to use it all the time, because it's such a good material, a good product for using inside the root canals to bond and open up those tubules. So the interaction between the sodium hypochlorite and EDTA, people talk about this a lot. In fact, some people used to say you should alternate the products. And so we're going to look at that now. Well, if you mix the products, then mix EDTA and sodium hypochlorite, you're going to get loss of the tissue dissolving capacity. And that's pretty obvious. So loss of the sodium hypochlorite's tissue dissolving capacity. And that's pretty obvious because, like I said, sodium hypochlorite is the person at the party who wants to interact. So what's it going to interact with? Is it going to interact with the tissue and biofilms and dentine? Or is it going to interact with the EDTA? Well, it's going to interact with EDTA. It's going to interact with anything you put in the root canal system. So if you start putting EDTA, and all it's going to do is just reduce the amount of available chlorine, which reduces the tissue dissolving capacity and all those things we spoke about. The EDTA still retains its calcium ion chelation after mixing, because that's a different way of working. And alternating is basically not recommended. Chlorhexidine, a very popular product for a number of years. This is 2% chlorhexidine that you can get. I personally think that you should use high percentage chlorhexidine if you're going to irrigate with it. Do not use mouth rinse. Do not use the 0.2% Savicol, because it's not designed for use in the root canal system. It basically works by, it has a very broad spectrum antibacterial effect and binds the cell wall. It has a good effectiveness against E. faecalis, which is that organism which we always talk about, Enterococcus faecalis, which is responsible for failure of root canals, or it's present, should I say, it's not really responsible for failure of root canal treatments. It's present in failed root canal treatments. Much of these treatments that is found in, though, have been poorly treated. I suspect that E. faecalis is present in the biofilm always, but flourishes in an alkaline environment. And if you don't treat the root canals effectively, you essentially push the environment of the root canals into an alkaline environment, and that just encourages growth of bacteria that love alkaline environments, i.e. E. faecalis. However, if you treat the root canals well, then E. faecalis either goes into a very dormant state and doesn't flourish, because it has no food and it's been entombed and a lot of it will be killed off by the medication. Although it's resistant a little bit to the medications, it's not actually immune. And Candida albicans is the other one it works against. It doesn't dissolve organic material. So again, as I said, there's not a single irrigant on the planet that dissolves tissue and is also an antibacterial product, apart from sodium hypochlorite. So every time somebody says to you, do you use this, do you use that? Does it dissolve tissue? Does it remove the food from the bacteria? Does it just change the environment? If the answer is it doesn't dissolve tissue, then you need to use sodium hypochlorite always, because as I said, the tissue is the food for the bacteria, and the bacteria will flourish if they have food. If they don't have food, they won't flourish. And that's a big part of endodontics. I think personally it's as important as removal of bacteria is removal of a food source and the ability for the bacteria to flourish. Because when we look at apical periodontitis, it will be related to a threshold level of bacteria and the amount of microorganisms. If we can reduce those right down and force them into a dormant state, then we will end up getting more successful cases than if we have a bacterial overgrowth in the root canal, of course. Controversy exists as to whether we should use sodium hypochlorite. It's got an antibacterial effectiveness, which is quite good. Ning's study, 2011, was a bit controversial, and 0.2% chlorhexidine was used, and they showed a decreased chance of healing. However, I would say there's a few problems with that research, given that they probably just used chlorhexidine in the cases that were very difficult to treat. They just threw it as a last resort, and they used 0.2%, which is way too low. Need to be using at least 2%. Shouldn't be mixed with sodium hypochlorite, because if you mix it with sodium hypochlorite, you end up with a brown material precipitate called parachloroaniline, which is quite toxic. You can only have 2 micrograms per kilogram per day as your maximum exposure. Otherwise, it's very toxic. So that's what happens is if you put the chlorhexidine in the root canal first, it will bind to the dentine. And then if you follow up with sodium hypochlorite sometime in the procedure, you will end up with this brown material. It also stains the tooth a lot. So it's difficult to get rid of. It's a bit like a kind of tea stain, so it fills up the whole pulp chamber. So the best way, if you want to use chlorhexidine and you think you want to use it, is to either use it at one visit and then don't use sodium hypochlorite, or use it at the end of the visit. You would have to use saline between the 2 irrigants. So sodium hypochlorite, then saline, then chlorhexidine. And if you use EDTA, then you produce a white precipitate thought to be a salt. When should we use chlorhexidine? Well, you can use it for cases where you suspect perforation. That's certainly a good case to use it for. It doesn't dissolve tissue, so it's got a good antibacterial activity. The other one that's quite interesting is it actually inhibits metalloproteinases in the dentine and improves bonding to the dentine. So there you go. And basically, you might use it in perioendo cases. You might use it in cases that you think you've got E. faecalis. I mean, basically, it's one of those areas that's a bit controversial at the moment, but I think definitely don't use the mouth rinse, use the proper products. So here's the irrigation protocol that I use commonly in, say, infected root canals. So you use sodium hypochlorite the whole time. Activate the sodium hypochlorite. Remove the smear layer with EDTA. And then rinse with sodium hypochlorite after you've used EDTA, because once you've removed the smear layer, you really want to get that sodium hypochlorite into those nooks and crannies. Activate sonic activation, ultrasonic activation, whatever you do, and agitate the sodium hypochlorite with gutta perca cones, because that will help to basically get the irrigants moving around as well. And also it will help to clean the cones a bit. You can wash the cones with sodium hypochlorite, but you should always dry the cones. And then you can use saline and chlorhexidine. It's an optional step if you want to, if you're worried about resistant bacteria or perioendo lesions. Personally, I don't use chlorhexidine that much, but as I said, if it was a perforation there, I would certainly think about it. Calcium hydroxide, it's the gold standard medicament. Why is that? Because there's classic studies showing that it has an antibacterial effectiveness, and it's only toxic to cells when placed in contact for a long time. So if you extrude this material, of course, we don't want it on a nerve in a canal or anything, or in a nerve canal. But if you extrude it, it will be removed by the body before it's effective. And if you have the medicament inside the root canals, it's locked in, safely locked in there, and it will have an effect on the bacteria. It works by increasing the pH and dissociates into hydroxyl ions. It creates a lipid free radical, so that transport protein on the cell wall that you might have seen when you were doing biology as undergrads. Basically, it interacts with that and causes lysis of the cell, so it becomes a lipid free radical rather than a lipid transport protein. It hydrolyzes this is another interesting point. It hydrolyzes the lipid moiety of the bacterial cell wall, the lipopolysaccharides or endotoxins. So there's a lot of discussion about endotoxins I was reading today, and basically our bodies have developed this hatred of endotoxins. And I've been thinking about this, and why is this? Well, so in other words, lipopolysaccharides are found on gram-negative bacteria, and our bodies are attuned to this, and they create inflammation. So what's the reason for this? Well, we know that gram-negative bacteria come in late in the game for periodontal disease when there's not much oxygen and when the biofilm is very developed. They're not they're not very hardy bacteria, but they do come along late in the piece. So obviously our bodies understand that if there are lipopolysaccharides around and gram-negative bacteria, that we have a high level of highly developed level of disease at this stage. So in the early stages of disease, of course, we have less gram-negative bacteria, but as time progresses, they come in as well. So this explains our dislike or the inflammation that lipopolysaccharides create. The increased pH denatures the enzymes of the bacterial. It's like changing the temperature, and it's just changing the environment to an environment that's less conducive to their enzymes working. Disrupts the DNA synthesis of the enzymes, again, denaturing them. It denatures the proteins, so denatures you probably read it, it denatures dentine, it denatures pulp tissue. So with the denaturing of dentine, that's quite minimal because it's only the surface, and we have decent thickness of dentine. With pulp tissue, it really helps to allow sodium hypochlorite to dissolve the proteins or dissolve the pulp tissue the next visit. So it's really quite useful for that. I use it in some external cervical resorption cases when I'm removing the resorption. Just fill it up with calcium hydroxide and leave it there on a cotton pellet, and it just helps to denature that inflammatory tissue. Disadvantages are that it denatures the proteins of the root canal system as well, so you'll get possibly some weakening of the teeth, but this is really not well proven, and a lot of the studies have a tiny slice of dentine in a vat of calcium hydroxide, and that's not very clinically applicable, and whether that makes a difference or not, I don't know. I think, to be honest with you, the bactericidal effect of calcium hydroxide in high concentration is much more important than some minor demineralization of the dentine. And it might have a limited effectiveness against E. faecalis, but as I said, E. faecalis is not immune from calcium hydroxide. When should we use calcium hydroxide? I would use calcium hydroxide in all the cases that have had the pulp removed. So in other words, you've cleaned the apex, in any cases with necrotic pulp, and any teeth that are pulpless. So it's effective at killing bacteria. It's effective at removing their food source. So I would use it in the cases that I see. I would use it every time. But there are cases where you wouldn't use it, and I was going to talk about that in a second. Or you might decide not to use it. How long should I dress the canals for? Shogun's study, as I said, 1 week versus 10 minutes. 1 week was effective at eliminating 100% of the microbes. Esperard did a study on how the pH diffuses through the dentine, and found that a pH of level 10, at which bacteria can't grow, took 18 days to occur. So, you might want to dress longer than 1 week. If you're looking at clinical outcomes, Rakuchi's study, 2 weeks was his best success rate with calcium hydroxide dressing. But for me, this would indicate that the longer you leave it, the more chance there is of leakage, and the more chance there is the patient dislodges the restoration, and that's a problem. No medication has a lower success in his study. Personally, I use calcium hydroxide. I think 2 or 3 weeks is my go-to. It depends on how many patients I've got booked in. But if you can seal the tooth up, you can put it in longer. I'd say restorative failure or restorative leakage is a factor in that. So if you cannot get good sealing of the tooth for a long period of time, like let's say it's got root caries or something, you seal it down, I would say 1 week and then get the patient back as quickly as possible and get that restoration. Remember, cleaning the root canal is like cleaning a room in your house. If you don't restore the tooth at the time and do it nicely, then it's like leaving the door open. Vera's study in 2012 looked at calcium hydroxide and histology and found it removed more bacteria than not placing it. Here's a case, tooth 27, patient 70-year-old female, and they required painkillers at night to sleep. Doesn't report any sensitivity to hot and cold, but has a throbbing pain on the upper left. The patient's taken a course of antibiotics, which has helped with the pain, so there's some infection going on, and tooth 27 has tendon percussion. There was no response on clinical tests to cold, and tooth 27 obviously have a periapical radiolucency. You can see it's actually a radiolucency mid-root of the mesiobuccal canal, and I was a bit worried about that, thinking it might be some sort of crack or don't know what's going on here. So what's the diagnosis? Well, It has no response to cold testing, so it's a necrotic pulp, and the signs go that the patient hasn't got any sensitivity to cold, and that goes along with that. The throbbing pain, this is also part of the diagnosis, so it tends to be occurring in teeth that are infected, necrotic, and so the diagnosis is to the symptomatic apical periodontitis associated with a necrotic pulp. How would this influence your irrigation and medication regime? Well, essentially, with these patients, if you would see the patient for an emergency, you would want to open the tooth up and get patency. The inflammation is mostly under the tooth, because that's why it's sore in the patient. You touch the tooth. And it has very limited inflammation at this stage inside the root canals, because the tooth doesn't respond to cold. So we need to get patency here and drain off that inflammation. If there's swelling, we need to incise it. Sometimes I prefer, if the patient's got swelling, to incise and drain from inside the tooth. And then painkiller regime, reduce the bite. That's another good tip. But how would that influence my irrigation and medication regime? Well, it basically means that I'm going to use sodium hypochlorite the whole time, EDTA to remove the smear layer, and also medication, calcium hydroxide, because there's no pulp in the tooth, or the remaining pulp, we want to denature that pulp tissue, because that's the food for the bacteria, and when we get them back next time, we need to be able to dissolve that out more readily. And here's the root canals. This is a true anatomy case, so interesting anatomy on that tooth. You can see there's the lateral canal is actually coelar puff, so it's just a little lateral canal mid-roots. Lidomix and odontopase, a steroid and antibiotic combined. Both of them are, Lidomix has tetracycline and odontopase has clindamycin. The steroid suppresses the inflammation via the arachidonic acid cascade, blocks the prostaglandins and leukotrienes, so it's quite a strong anti-inflammatory steroid. The dimethylcycline binds to ribosomes and prevents protein synthesis, so it's bacteriostatic. Again, it's in red because it's one of those sort of things, if you're looking at distinction marks, and if you're looking at improving your knowledge. Tetracycline binds to calcium and causes staining, so I don't use this in anterior teeth for sure. One dose of the antibiotic has limited effectiveness, of course. Antibiotics used once aren't that effective. There's no additional benefit from removing necrotic tissue, so it doesn't help to denature the proteins in the pulp tissue. And Effie Ehrman did some research that showed that perhaps it has some improvement in its post-op pain in patients after using it. But then he found that it doesn't prevent flare-ups. And the reason why this occurs is because the flare-ups are actually from extruded bacteria and dentine chips and irrigant solutions on those dentine chips. And if you extrude stuff, then any medicament inside the root canal really isn't going to affect that. Your problem is outside the root canal when you've extruded stuff, and it's inflammation to that outside of the root canal. So you're not going to get improvement by putting something inside the root canal. And I'd say that's what that is due to. Pain inside, post-op pain is very subjective, and that's quite an interesting study, but unfortunately the flare-up study doesn't show any improvement. So when should we consider using them? Well, we might consider using them when we haven't got much time and we can't remove all the pulp tissue. So you would scoop out the pulp tissue. For example, if you have a patient with a hot pulp, they say, I've been up all night, I can't drink cold water, or sometimes the cold water makes my tooth feel better and the hot water is like driving me crazy. And you get into the pulp and they start moving around saying they're in a bit of pain. You might just, if you haven't got much time, obviously, I tend to extirpate all the pulps. I've got a great team, and they book me long appointments and treat me kindly. But back in the day in the UK, I didn't have that luxury, and I used to get lots of walk-in emergencies. And in fact, it was quite funny. My boss used to say to me, you have to see all the patients on your list, and there were 1,700 patients on my list, and I was seeing patients for emergencies, and you'd get them in and you just extirpate. So if you have a hot pulp, you need to just scoop out the pulp, put the leather mix on. I used to use a cotton pellet with soaked leather mix and put it on the pulp and just close that defect, and that would help for a bit. But beware that when you get them back next time, they'll be having inflamed pulp below that cotton pellet. So you need to just spend the time to get them done. So Adonna paste is triamcinolone and clindamycin, and it has an anti-inflammatory effect as steroid. But Adonna paste doesn't discolor teeth, but it might have some resistance in the E. fecales. So here's tooth 47, 45-year-old male. He says he has pain at night and requires painkillers to sleep. He has severe pain to hot and cold liquids. And tooth 47 is tendon percussion and hypersensitive to cold testing. So try the 4-6, can feel it, get them to put their hand up, feel that. It always makes me laugh though with patients. You say to them, I'm going to put some cold stuff on your teeth. When you feel the cold, put your hand up, and they don't do anything. And they go, oh, and they don't put their hand up. And I think to myself, have you listened to a word I said in the whole consultation if you don't put your hand up straight away? But it shows you patients probably don't listen to us too much. But then they put their hand up the second time. So the 4-7 hypersensitive, puts his hand up and then just keeps it up. Please don't touch me with that cold thing again. That was really bad. So that you know that the tooth is like a pulpitis. No periapical radiolucency because the density of the bone in the 4-7 region, but also just generally it's an early infection. It's not spread to the periapical tissues enough to show on the radiograph. There will be a radiolucency there because the tooth is tendon percussion. It might show on a cone beam scan, but it really wouldn't show on a radiograph at this stage because the paper by Seltzer-Bender and Zionitz showed that you need to have a hole in the cortical plate to show on a radiograph, and you can see something if the periapical lesion's not creating a perforation of the cortical plate. You sort of see something, but it's not very obvious. And that's why cone beam can be useful in some situations. What is your diagnosis? Diagnosis is symptomatic apical periodontitis because it's tendon percussion, associated with an irreversible pulpitis. If you saw the patient as a walk-in emergency, how would this influence your irrigation and medication regime? Well, it would just basically mean that I would be inclined to anesthetize the patient and then clean out the coronal pulp and possibly place a steroid antibiotic paste and then close it all up. Because then you've removed a bulk of the microorganisms in the coronal part, because these teeth have more bacteria coronally than apically, because that's the pulp is actually fighting the bacteria off from the coronal region, and they haven't really reached the apical regions. And you can then close off the defect, which is obviously that restoration there. Once you've closed the defect and removed the bulk of bacteria, the inflammation will subside. Here's the root canal treatment. Nice, interesting paramolaris here with 2 mesial roots. Mixing leather mix and Adonna paste really doesn't have much advantage. In fact, the steroid component is removed by the calcium hydroxide. So mixing calcium hydroxide and Adonna paste and calcium hydroxide and leather mix, the steroid is degraded by the calcium hydroxide. Mixing chlorhexidine and calcium hydroxide, that's another thing I've heard. The pH of calcium hydroxide is unaffected by the mixing, but some studies show it's effective. Some studies say it's not that effective. I mean, when you think about it, there's a positive ion. Chlorhexidine is very positively charged, and that's how it works. And calcium hydroxide releases hydroxyl ions. So they sort of the tendency is to me to think that they cancel each other out. So that's something that I wouldn't recommend. What's the future of irrigation medication? Well, nanoparticles. We've all heard about zinc oxide. It's in all the creams and it's in a few restorative materials. Has an antibacterial effect, but if it's made into nanoparticles, bacteria will take this up. The idea is that they take this up and it creates reactive oxygen, which is antibacterial. There is antimicrobial photodynamic therapy. This is using a light or a laser. You can use a methylene blue. And this will create singlet oxygen. And so you can use the nanoparticles like a medicament, and you can use the antimicrobial photodynamic therapy like an irrigant, and you can activate that with a light. As I said, it creates singlet oxygen, which is antimicrobial, and also has a limited effectiveness on fibroblasts, so it's less damaging to our cells. There's an article here by George and Kishan. So lasers. Well, lasers are a bit of a controversial one. There's my favorite James Bond scene. Do you expect me to talk? No, Mr. Bond, I expect you to die. That's actually quite an interesting name. Auric Goldfinger was actually the name of a guy who developed a property that I used to live next to in London. And apparently Ian Fleming, who wrote the novel Goldfinger, actually lived in the area of London, or near the area of London where I did, and he saw this horrible tower go up, and it does look pretty horrible in the city. And he said, who constructed that building? And they said it's Auric Goldfinger. So they changed the name of the bad guy in his book to Auric Goldfinger, who was actually the architect of that building, or the person who designed the building. That's quite funny. So there's singlet oxygen creation with a laser. You can, as I said before, you can activate these methylene blue. And then you've got this photo-induced photoacoustic microstreaming, which is really what's been quite popular. Agitation by using photoacoustic shock waves. So this has been shown to cause cavitation and bubbles and all those things I said might not happen with our other activations. And so this is an area where lasers may be the future. PIPs, or photo-induced photoacoustic microstreaming. It really could be that lasers have a little few things like, disinfection of the root canal around corners and things like that might be difficult. There's a whole lot of things like the probe has to be quite small. If you're preparing a root canal to a size 40, 45 or whatever to get the laser down, then the preparation's done. So, but there's certainly room for lasers to come into endodontics in the future, and the photon-induced photoacoustic microstreaming, as well as the activation of the creation of singlet oxygen by those toluidine blue, methylene blue, maybe some way to have lasers in our treatment. So conclusion, irrigation and medication encompasses 50% or more of our disinfection of the root canals, as we saw by the classic study, Bistrom and Sundquist. First, tissue dissolving and biofilm dissolving and antibacterial properties. Sodium hypochlorite is the gold standard irrigant. As it lacks the ability to dissolve organic smear layer, then we have to use EDTA. Chlorhexidine might be an alternative where there's a perforation suspected. It doesn't dissolve tissue, but it has good antibacterial effect. Recommend using 2%, not the mouth rinse. Due to its long antibacterial effectiveness, calcium hydroxide remains a gold standard medicament. Nanoparticles and irrigants. Nanoparticles may be a way to gain access to the cell, because again, our irrigants medicaments work on the surface of the cell, or they work on biofilms. We need to be effective, they could be taken up. So nanoparticles are taken up by the bacterial cells. So this is somewhere where it can certainly be useful in the future. So thanks for listening, everybody. I just thought I'd leave my contact details here. I've got a few social media pages and email. The Facebook page, Specialist Endo Crows Clinical Hacks, I started about 10 years ago now, with a few friends from Otago, telling them how to get down canals and stuff. And now we have lots of people all over the world. So it's great. And thanks for everyone who reads those posts and says they enjoy them. I really appreciate your messages that I get. The Instagram, we started 2016 at Specialist Endo, and it's a bit more about cases and perhaps visual stuff. And we've got the email info@specialistendo.com.au. And so thanks to the team at Ultradent and Fabio for inviting me to do this presentation. And I hope everyone got lots out of it. And now we'll get on to some questions.
Well, Omar, wow, thank you. Thank you so much. And we do have quite a few questions here. And I don't know if you can access them directly. We have some that are a bit redundant, so I can group them into topics. Okay. If you click on Q&A there.
Yep.
There's one that's always, a recurring question in every endo webinar, which is a few people asked here as well. When would you recommend a single visit versus multiple visits? And Yes, there's one variation. So if you want to address that, and I can find the other one that had a variation on it.
Yeah, so that's a good question, because so single visit, as I explained before, the bacteria in the root canal are found in the coronal area in pulpitis cases. And so if the tooth has got a pulpitis, actually when you remove the pulp, you actually remove the thing that's fighting against the bacteria. So you don't want to remove the pulp unnecessarily and just temporize it, and then it leaks, and then you've got a worse situation. So you can actually do a single visit treatment on pulpitis cases if you have the time. That's the problem, is if you have the time. Teeth that have been extirpated previously by maybe an emergency dentist and are asymptomatic and were symptomatic, I'm happy to do single visits on. There's all sorts of reasons why you might do single visits, but the textbook answer would be no periapical lesion, pulpitis case, a few things like that. And maybe I would say if the tooth's been extirpated and the tooth is now asymptomatic, the first dentist has done the first stage for you and got the patient out of pain, then unless there's errors that you can't correct, then you could consider a single visit. Really, it comes down to a couple of things. First of all, patient management. You don't want to finish the treatment and the patient doesn't get success. You want the patient to be with you all the way. So, if they've got a persistent sinus and you open up the tooth and clean it all out and then dress it, and then the sinus goes away and then you complete the treatment, that's logical. If you have a persistent sinus and you open up the tooth and treat the tooth in one visit and fill it up, and the sinus didn't heal, then the patient might be aggrieved that you didn't wait and see, and there's a few things like that. So a lot of it's patient management as well as science. And also, patients who take antibiotic cover are more likely to do single visit. Patients who are under GA, we have GA facility at our clinic, and they're more likely to get a single visit treatment because they're going through a general anesthetic, but not all the time. I mean, obviously, if they have a persistent sinus, I'm not going to do a single visit. Or if they have a bigger abscess, I'm not going to do a single visit. So that's basically a rundown for that question.
Thank you. All right, there's another recurring question here came when you were talking about medications, particularly calcium hydroxide. So some questions about what are your tips to deliver those, and if you wouldn't be concerned about extrusion when applying with a syringe. And also, after maybe if you address that, how would you remove that afterwards as well? It was a question that came up.
Okay, so calcium hydroxide delivery, I use the Navi tips. I use the 30 gauge Navi tips, 25 millimeters long, because I had to order some the other day. They have a stopper on them. I put them about 1 to 2 millimeters short of the working length and inject the calcium hydroxide. But I don't lock it's like irrigating. I don't lock the needle at the apex and then force it. I would, first of all, I make sure that the calcium hydroxide is extruding from the tip before I go near the canal. Just put a bit onto a pad, and then that's coming out fine. Then I inject the calcium hydroxide. If you're really worried about getting it down the canal, you can use some of those activation methods to get it down the canal. So say if you inject a bit, but you're a bit concerned that injecting will cause extrusion, you can just fill the canal to where you feel comfortable with, and maybe use an endo activator or whatever activation system, Eddy Endo, to pass the calcium hydroxide down the root canal. For removal of calcium hydroxide, you wanted me to talk about extrusion, so I'm not too worried about extruding calcium hydroxide unless I extrude onto a nerve bundle or into the canal of like the mental nerve and things like that, the mental foramen. And basically, if it doesn't go near these areas, you will get little or no problems, because calcium hydroxide has to stay in an area for a long time to be effective. We spoke about that breaks down and slowly breaks down over time and releases hydroxyl ions. So if it's sitting in the tissues, it just gets removed by the body. What you don't want is it sitting on a nerve for a long time. So yeah, I mean, I'd be concerned in some areas of the patient's body, but not others. So that's regarding the extrusion. Removal of it, you can use the activation product. I actually use the way I do treatment is I prepare most of the cases when I see the patient to a shaping file size or a smaller size than I would go to. Then I would dress the tooth with calcium hydroxide, seal it up, and then when I get the patient back in, I would use the final finishing file. So that just widens the canal and also removes the calcium hydroxide at the same time. So that's the way that's my preference, rather than prepare the whole canal and then have to use hand files to get it out.
Citric acid would be an option there as well, right? To dissolve.
Yeah, correct. Citric acid. Yep, citric acid. Yeah.
Great. Let me see some more questions here. The time that you irrigate for with sodium hypochlorite.
The time, so you saw the 40 minutes. Well, it's the whole appointment. So I'd see most of my patients, I'd see twice. Very few single visit cases. If you're doing a single visit case, you want to be irrigating for 40 minutes, but 40 minutes is over the whole appointment. So that's the minimum. And when you think about it, when I do single visit treatments, they're around 1 hour, 45 minutes or something like that. So you easily get in 40 minutes of irrigating, but as I said, that's not continuous irrigation for 40 minutes. It's irrigating, preparing, and irrigating, activating. So I would say time for irrigation, always aim for 40 minutes or more based on that paper.
Okay. In cases you plan to place a fiber post, do you rinse the canal with extra irrigant before placing the adhesive cement?
Now this is a good one because you could use chlorhexidine. As I said, it improves bonding. You could use you definitely want to use EDTA to open up those tubules. So I would do that. Yeah, that's really what I'd do. If you're not using chlorhexidine regularly and you don't have it, then you could use EDTA and just open those tubules up a bit.
All right. If a referrer used chlorhexidine prior and sent for retreat, would that pose any risk of forming that brown precipitate?
Well, it does have a limited time for its binding to dentine. I think it's something like, I'm just guessing here, but I think it's something like 8 hours of binding. So if you saw the patient within 8 hours, you would have that precipitate. But the chances are most patients have had enough of root canal treatment when they've had it one day, unless they're coming the very next day or that same day, then you really wouldn't get that forming. So, so this is why you can use chlorhexidine at the end of the appointment, and then if you saw the patient in like a week's time, you could still use sodium hypochlorite. It's a limited time that it's got substantivity, but it doesn't last for more than about 8 hours. I think that's the figure I've heard, but I'm sure it varies. But it's not more than a day. So if you saw a patient the next day, you would be absolutely fine using sodium hypochlorite.
Okay. I have a question here on EDTA paste. So I use an EDTA paste with rotary files. Would that reduce the efficacy of sodium hypochlorite?
So no, because it's EDTA. But the EDTA, does it say would it reduce the efficacy? What was the question again? Did it say
if you use the paste? If you use a paste, would that reduce efficacy of the sodium hypochlorite?
Yes, it will, because it will interact with the sodium hypochlorite. All the gel and the waxes and everything that will interact with the sodium hypochlorite. And as I said, it wants to interact with everything. The other thing that I would say is that viscous chelators or EDTA gel, there's a few of them. There's lots of different types. You should use that. You should not use that on rotary files. And the reason why is that you're essentially loading the blades with a substance which will attract debris. And we know that if we attract debris to the file, we reduce the cutting efficiency. Cutting efficiency, which is reduced, does not cut efficiently, obviously, and this will produce more stress on the file and prevent it from cutting through. That will increase the stress on the file. So you should not use viscous chelator when you're using rotary instruments, but you can use it on hand filing instruments. And the reason why, it does the same thing in hand filing instruments, but in hand filing instruments more narrow, and we have more tactile sensation, so we can overcome this issue. So yeah, one of the things I definitely don't recommend is using viscous chelator on rotary files. There's a famous little statement that I heard when I was traveling from one of the lecturers. He says, if it spins, irrigants win. So use irrigants when the rotary file is spinning. Don't use viscous chelators. And yes, it would reduce the efficacy of sodium hypochlorite because it's going to start reacting with it.
I got a couple of questions on RC prep while we're at it as well.
Yep.
So is the EDTA content in it sufficient to get the benefits of an EDTA irrigant, or does it really need to be in a solution form?
Yeah, it really needs to be in a solution form. Essentially, these viscous chelators are just to unblock root canals and try to create a glide path. They're not really going to get in the nooks and crannies, and they haven't got the flow that you need with the irrigant. The irrigant's a really important part of the process because, well, it's documented in the research that it helps. So if it helps, then it will help disinfect the root canal. It'll open up the areas for that.
All right. Questions, it's incredible. I keep hitting answer and dismiss to some questions, and the number keeps coming up. We will have to put a ceiling to it, or else we'll just go through the night. Maybe let's go for a handful more here. And again, I don't know if you have access to them. If you see, and the list is quite long, and thank you everyone for sending your questions, really.
Yeah, thanks for giving up your time and asking questions. It's great.
Yeah, we were just around 600 participants for the most part, which is tremendous and very interactive as well. So the questions, so let's see here, really try to make, see something that we haven't talked about yet. Sodium effective. Okay, here's one. How would you manage a tooth with a large periapical radiolucency? I was told from a colleague to do multiple visits dressing with calcium hydroxide and monitor the healing of the bone for months before going ahead to obturate.
Okay, this is a good question,
so
actually.
With a large periapical, yes.
Yeah, so assuming the periapical lesion is due to root canal disease or endodontic disease, and it's not like a fracture or some other thing that's the diagnosis. So assuming that's correct, yes, I would. This gets back to a little bit of the patient management aspect. You show the patient there's a big problem, and like I had this actually the other day. This patient came in and same. They've had long-standing periapical lesions, not much pain. Two molars next door to each other, and I said exactly that. We will clean these root canals as well as we can. We will lock in that clean environment. We'll use the calcium hydroxide, and we will review you in 4 months' time. The reason why I said 4 months was 3 months is the minimum time for healing if you take out the tooth. So if you, should I say 3 months is the time it takes if you take out the tooth for it to heal on a radiograph. So in root canal treatment terms, it's the minimum time for healing. So if you were to have no bacteria present, no root canals present because the tooth is out, the radiograph would take 3 months to heal, around 3 months approximately. If you have a tooth that's root canal treated, we're always going to have some level of infection and inflammation going on. They haven't had a hole made to drain, obviously, all the inflammation, and it's all cleaning inside the root canals, and there's inflammation outside the root canals as well. You're going to get slower healing, but it can take 3 months. So that you can't get healing that's quicker than 3 months with root canal treatment if it's infected quite a lot. So I usually say 4 months. I wouldn't. I mean, again, it depends on how you can restore that tooth. If if the tooth's difficult to restore, you would want to see the patient maybe 6 weeks, 8 weeks later, and then redress, and then maybe do that 3 times and then get them back. So you need to have that 4 months, but it needs to be sealed for 4 months. It can't be like leaking for some of it, and because it'll just get reinfected again. So essentially that's correct. I would recommend reviewing, and then again, it's got to do with the patient's symptoms, the patient sinus tract heals, some of the healing bone. That's a good protocol to follow, because if the patient's on board and sees changes and you see changes, then you've got a reason to complete the treatment. And I think that's a good thing. Again, if you have done this and you follow the protocols, you can say to when let's just say the treatment down the track needs surgery. Well, you can say to the patient, I've done everything I can to help you, and we've been monitoring it, and it's been going well, and now you need surgery. Occasionally we do get cases where there's a large periapical lesion on, say, an anterior tooth. You clean out the root canals and the sinus tract heals, and you go, oh, this is good. And you finish the treatment, and then 6 months to a year later, the patient comes back, the sinus tract comes back. But the patient feels fine because they feel that they've been looked after and you've monitored and done everything you can. And they've got the cleanest root canal possible. You haven't done it too quickly, you haven't rushed things, and they felt looked after. So that a lot of this is patient management and making sure they're on board, you're on board, and things are going well. So that's definitely a good thing to do, is to monitor for healing. But you have to be able to restore the tooth and lock it down so that it can be sealed for a long time. So your review period will depend on how the sealing of the tooth is. Like, in other words, how easy it is to seal it. If it's an occlusal cavity and you can seal it up for 4 months, no problem, no need to change. But if it's root caries and stuff, you're going to have to really get down there. And the material I really like for sealing deep down, if you're going to seal it for a long time, is actually IRM. It offers a good antibacterial. It's got zinc oxide eugenol, right, and it's good.
Okay. A couple of questions here from Dr. Adriana Aquilia. Could you please specify the needle gauge and brand option supplier? You've mentioned some about that, and she also asks about your thoughts on lentulo spiral.
Okay, so I don't use lentulo spirals because I use activation units to place the calcium hydroxide. So I'll use endo activator or Eddy Endo. I inject the calcium hydroxide, so I don't feel that I need to spin it down the root canal. So I haven't used a lentulo spiral filler since dental school. The other one about needles, so there's lots of different needle types. You've got 30 gauge needles. I believe you have the Navi tips. Ultradent does the Navi tips and the 31 gauge. So the 31 gauge is a 25 K file size, so that's quite handy. And with a double side port, as I said, that improves the flow of the irrigants. There's also, I've used the True Anatomy irrigation needle dense by Serona one, which is plastic. That's quite neat for True Anatomy. And I think if you're doing micro endodontics, you should be using some kind of micro irrigation tip. And along with that tip, activation is part of working the irrigants down the canal, and again gets you over that vapor lock, which is going to occur.
All right, let's go for maybe one more question, and then wrap it up. Which is a shame, and I apologize for that, but we can't humanly. We keep the same number of questions, and I'm trying to filter so we don't have redundancy here. This is a question from Dr. Helen Mahir. She had some very good questions here as well. So if you have an emergency extirpation and the tooth has hot pulp, do you change your irrigation protocol? And on that note, there are quite a few other questions as well. Which irrigation would you prefer to use in cases of apicectomy, fracture? So when would you change your protocol? You addressed some of that, but if you could.
Oh yeah, so if the tooth's had an apicectomy. Okay, so regarding hot pulp, okay, so I won't change my irrigation protocol too much for hot pulps, but if you're doing a pulpotomy, you definitely don't need to use EDTA. So in other words, if you're just going to scoop out the pulp and then you're going to dress and then you're going to see the patient another day when they've got more time, you don't need to use EDTA, because what you need to do is just remove that pulp tissue, and you're not going to create a smear because you're not really instrumenting the root canals. So you would use sodium hypochlorite, but you wouldn't necessarily have to use EDTA unless you're instrumenting the canals and creating a smear. The other thing about hot pulps are that obviously there is not much bacteria apically. So EDTA is of limited effectiveness in these cases anyway, but you do use it because, of course, it gets hypochlorite into nooks and crannies, gets rid of the pulp tissue, and that's what we're trying to achieve. But in the first appointment, you could probably get away without using EDTA. That's one of the changes. And you had another question about something else.
So was fracture, apicectomy, and all
Yeah.
sorts of variations here. So if you would use chlorhexidine instead, and apexification.
Okay. Yeah. So, I mean, with those kind of situations, you could certainly try and use chlorhexidine for these kind of situations if you were concerned. You would want to use sodium hypochlorite at some point during the process, because otherwise you don't get tissue dissolving property, and these apexification cases have a lot of pulp tissue, and you need to be able to remove that. As I said, that's a food for the microbes. So, but you certainly could say do the first visit with chlorhexidine if you felt you were worried about extrusion. You were worried about where your working length was, and you can get all that under control on the first visit. Because if you extrude on the first visit, the patient's going to be really upset, and also it's not very nice for everyone. But once you've got a safe working length, then you can easily use sodium hypochlorite. In fact, a couple of cases that I treated when the perforation's been present, the dentist has referred the patient, and I've used chlorhexidine for the first visit, and the second visit I used sodium hypochlorite once I've repaired the perforation. If the tooth has had an apicectomy, if it's been sealed at the apex, it won't change my irrigation protocol because you're not going to extrude. Also, you can feel the retrograde restoration. So if it's a dead stop at the end, you're pretty safe there. Obviously, you're going to take radiographs and check that as well, but you will feel that you have the sodium hypochlorite within the root canal system. So really, it depends, but chlorhexidine is kind of my irrigant if I'm unsure about anything, which is not much of the time, to be honest. But it would be like if you were worried about a perforation. For example, if I get referred a perforation case and the perforation is quite big, I would not use sodium hypochlorite because I use quite strong sodium hypochlorite. I would be worried about it getting out into the patient's tissues, even if it's a large perforation. I would tend to use chlorhexidine.
Excellent, thank you. All right, I would like to invite everybody to follow Dr. Omar Ikram on Instagram. You can see there on your screen at Specialist Endo, and he left his email there as well. And we, even invite you to send some of those questions to him. Omar, I'll have an Excel sheet with over 100 questions here, well over 100 questions. And once again, this is a great sign that everyone was engaged, and a great presentation. Again, just thank you so much for putting things in such an organized way for us, and for sharing some of your broad knowledge on endodontics from all different perspectives, from the guerrilla style of endodontics you performed at NHS in the UK, and to now that you can have a little more time and schedule a little more time to see some patients. So it's great to absorb some of that experience from you, and we really appreciate your time, Omar, organizing, coordinating, making sure that this went as well as it did, and all the way to the perfect execution of this. Thank you so much.
Thanks, Fabio, for inviting me. I really appreciate it. And everyone else, obviously, for watching the presentation and asking questions. I really appreciate you giving up your time to watch this and ask questions. So thanks heaps for coming, and hope to see you soon, and keeping safe.
All right. So as a final note, again, beyond following Dr. Omar on Instagram. I invite you as well to follow Ultradent. We have different channels depending on the parts of the world that you are. Ultradent ANZ, Ultradent Southeast Asia, Ultradent Nordics, Germany, Brazil, whatever you are. And we also have a blog. Actually, this week we posted something on irrigation protocols as well. And the address for this blog is ultradentapac.com, so APAC. And if you send an email to info.anz@ultradent.com as well, which is the email from where you received the confirmation for this webinar, we would be happy to share with you a link with the recording of this webinar if you missed a part of it. Okay, and or if you have any questions about this webinar, we would love to hear from you as well. So with nothing else to say here again, thank you everyone for your participation. And Omar, once again, thank you for this excellent presentation tonight.
Thanks a lot.